Health and Preventive Medicine at Monash University and an NHMRC Investigator Leadership Fellow. She's the lead investigator of Wiser Healthcare, which is a national research collaboration. Denise is an implementation scientist and health services researcher, and her research explores the causes of and the design and evaluation of solutions to address research translation problems. And the topic of her presentation today is using implementation science to drive the right care. Thank you very much, Denise.
Thanks, Caroline, for a nice introduction and for the invitation to come and speak with you and everyone who's made time out of their day to join today. And when I was speaking with Caroline in the lead up to this presentation, she really asked for a sort of a implementation science 101 on sort of the general principles for designing research translation interventions. So I hope it will be of interest and value to everyone today. There might be people on the call who, you know, are familiar with lots of these concepts and others for whom they are new. So feel free to ask questions or note questions and we'll come to those at the end of the presentation. Okay, so I will share my slides and Caroline, just let me know if you can see them okay.
Yep. That looks good. Yep, perfect.
Great, fantastic. Okay, so I would like to start by acknowledging the people of the Kulin Nations on whose land Monash University operates and the traditional owners of the land from wherever people are joining today. And I pay my respects to their elders, past, present and emerging. And so, as I mentioned, I'm going to spend the next 30 minutes or so providing really an introduction to research translation concepts and implementation science. And specifically, I want to cover why research translation is important, although probably we're all pretty convinced of the reasons for that. Some key definitions and terms. Then talk firstly about what research should we be translating and then how should we be translating research into practice informed by implementation science, theoretical and empirical knowledge. And then I'll pepper the talk with a couple of examples from my work. I haven't drawn in a whole lot of AMS examples because people on the call will have some of those and maybe we can talk more about that in the Q&A. So the importance of making best use of research is not a new concept. And in fact, it was back on the agenda in, the 1930s when then Minister for Health, Billy Hughes, said that research must be actively pursued and developed. And as fast as that knowledge is acquired, that it must be applied. And failures of research translation have also been known for quite some time. So this editorial was published almost 2 decades ago now by Stephen Wolfe in the Washington Post. And it really called for more effort and funding to be allocated to translating proven, effective tests and treatments into routine care, rather than focused on medical breakthroughs. And you can see unhealthy medicine, it's all about all breakthrough and no follow through. And so the argument here was that there was no follow through of existing research into routine healthcare practice, and that the hundreds of billions of dollars of investment per year worldwide in biomedical and health research wasn't being capitalized on, but was being wasted because of those research translation failures. Which we know leads to, saving more lives and improving patient outcomes. We also now have consistent evidence from Australia, both across the country in specific, across different clinical areas, and also from many other jurisdictions around the world, demonstrating that evidence-based effective care is delivered on average 60% of the time, whilst 30% of healthcare provides no or very little patient benefit, and about 10% of care is harmful. So this is referred to as the 60-30-10 rule. And not only does this waste our finite healthcare resources and waste clinician time, that could otherwise be directed towards this high-value care, but it negatively impacts the healthcare of patients. Low-value care does little to help them, and in some cases you can see here harms them. And it also, we're learning, is starting to contribute to the climate crisis by actually contributing avoidable carbon emissions, because healthcare in itself is a contributor to carbon emissions. So we want to make sure we're delivering effective care. And of course, I don't need to tell this audience about the growing, ongoing threat and problem of antimicrobial resistance and the critical need to improve antimicrobial prescribing appropriateness across One Health. And while we know that there have been some improvements over time, the data from the recent AURA report and also the NAPS audits show that about 1 in 4 antimicrobial prescriptions in hospitals remain inappropriate, and that also aged care homes should be a major focus for research translation efforts. So what are we talking about when we're referring to research translation? Well, it's about ensuring stakeholders, that is, we as healthcare providers, consumers, policymakers, educators, researchers, and also funders are aware of and use research evidence to inform their health and healthcare decision-making, but also that clinical research and those researchers are informed by, and they actually advance or build upon existing clinical evidence, and also are informed by the experiences and information needs of stakeholders. However, what we do know is that being aware of existing clinical evidence is a necessary but not sufficient requirement to implement effective care into practice and de-implement low-value care. And we all know that research translation is a complex process, and it involves changes in attitudes, in systems and behaviour across individuals, teams, and organisations. So therefore, we need to draw on evidence to inform that, as well as theories from the psychological and social sciences that can help us to plan, describe, and explain these complex processes. So just as well-conducted clinical research provides robust evidence about the effects of clinical tests and treatments, so too we need an empirical body of evidence about the influencing factors, the processes involved with, and the effects of research translation interventions in order to optimise that right care. So this really developed or led to the development of implementation science as a discipline, and this is a sub-discipline of health services research, and it is the scientific study of methods to promote the systematic uptake of evidence-based clinical practices and the de-implementation of practices that are proven to be ineffective or harmful into routine practice, and hence improve the quality and safety of care and improve patient outcomes. Some of you may be aware that we have now 2 journals that are dedicated to publishing this type of research, but also increasingly other journals, discipline or topic specific, are also interested in publishing implementation research related to their areas. Now, because research translation involves changing attitudes, behaviours, systems of individuals, teams, and organisations, several reviews of relevant theories, frameworks, and models have recently been published. And this is really to gather that information and make it accessible to folk who are trying to support research translation efforts in their organisation. And so first I want to touch on models, which are useful for guiding the overall process of research translation. And then I'm going to talk a bit more about theories and theoretical frameworks and how they're useful to actually design and evaluate research translation interventions. So about a decade ago, my colleagues led by Simon French and I published a model for developing research translation or behaviour change interventions that involved 4 phases. And this included first defining what behaviour change needed to occur to translate research evidence into practice. Second, assessing barriers and enablers to change, that was informed by relevant theory or frameworks. Third, selecting intervention components that are most likely to overcome the identified barriers and enhance the enablers. And this could be informed by, again, relevant theory, but also that research translation or implementation science body of knowledge. And then fourth, evaluating the outcomes of these interventions along the causal pathway of change. More recently, Jeremy Grimshaw, who's a leading figure in implementation science, as well as his colleagues from Canada, adapted that model with a specific focus on de-implementation of low-value care, which is increasingly getting more and more attention in the literature. And of course, we want to reduce that. And the way that they did that in this particular model is that they explicitly elaborated on that first step, and they identified the need to establish local priorities for de-implementation. And they really emphasised the need to get early stakeholder involvement. And this is particularly important, and they made the case that it's particularly important when we are trying to remove or reduce low-value care that's already in the system. They also added a step focused on spread of effective programs in step 4. So engaging stakeholders to prioritise which specific practices to target with research translation efforts is important at the outset. And this is because it primes readiness for change and it maximises the chances of success by bringing people along with you right at the beginning. And so here's an example from Eve Kerr and colleagues in the US, showing how they identified and prioritised recommendations for scaling back unnecessary primary care services using 3 steps. So they did a rapid review of guidelines and choosing wisely recommendations relevant to their particular scope of practice. Then they made the recommendations actionable. So who needed to do what to implement those guidelines or translate that evidence into practice. And then they also estimated the size of the evidence practice gap so that they knew or could estimate the impact if those practices were de-implemented. And then finally, they conducted a Delphi consensus process to establish what the local priorities for change were. So they got everyone or the relevant stakeholders on board at the beginning about where to focus their energy. So when thinking about what research should be translated, various sources can be consulted, and I'm sure you're familiar with all of these. We look at evidence-based clinical practice guidelines. And of course, we have the Australian Clinical Practice Guidelines portal. We also can refer to clinical care standards published by the Australian Commission on Safety and Quality in Healthcare. And these provide recommendations for the use or avoidance of tests and treatments. We can refer to systematic reviews of the effects of clinical tests and treatments, for example, in Cochrane Reviews, but there's many other journals that are, of course, publishing systematic reviews of clinical interventions. And then we also have Choosing Wisely Australia recommendations about low-value care that should that basically clinicians and consumers should question. Now, we translate bodies of evidence and evidence tools, evidence synthesis tools like guidelines, or clinical care standards rather than individual trials or individual studies. And that's because, firstly, there's just too many studies to translate. And so if we're focused on translating all of those, there's just too much going on in the system. And, you know, in 2024 alone, in June, there's over 2 million randomized controlled trials of clinical interventions. So way too much to translate. We also know the results of those individual studies vary, and in some cases quite substantially. So each of them need to be interpreted and translated in the context of a body of evidence. We also know that the effects of clinical interventions can lessen over time. So John Ioannidis looked at, you know, over 100 randomized trials of clinical interventions and tracked their effects over time when they were replicated or in subsequent studies, and saw an attenuation of the effects. So hence we need to translate syntheses of evidence or guideline recommendations based on syntheses, and also replicate studies. And then finally, single studies rarely provide the sort of evidence that we need for widespread practice and policy change, especially because in many clinical areas, there's small studies conducted in specific populations. So it's more useful to draw on bodies of evidence. So after establishing what research should be translated, drawing on guidelines or clinical care standards or systematic reviews, then it's important to specify the behaviours that need to change to translate that evidence into practice. So for instance, who needs to do what differently? Now, why do we need to be so behaviourally specific about this? Why do we focus on this at the beginning? Well, that's because first, research translation efforts rarely involve the change of a single behaviour of a single individual or a group of individuals. Often to translate evidence into practice, there are multiple behaviours involved for multiple actors in the system. So we need to be very clear about what those behaviours and what the behaviour change is in order to support that process. Also specifying change in this behaviourally specific manner will lead to a better, a more accurate assessment of what the barriers and enablers to change are. And that comes in, you know, subsequent steps of this model. And often the barriers and enablers are different for different groups of, you know, actors and for different behaviours. So we need to know what the key behaviour change is for those different actors. And so Justin Perceau, again, a colleague from Canada, and others have elaborated on this, who needs to do what differently step, and described the ACT framework. And so here you can specify who needs to do what differently, when, where, and how often. And here's an example: improving hand hygiene in hospitals. So it involves multiple actors. For example, clinical staff, doctors, nurses, allied health, cleaning staff, and administrators need to do different things. So the primary behaviour that all clinical staff need to do is obviously use alcohol-based gel before and after touching patients. However, in order for that to happen, ancillary behaviours include cleaning staff checking and refilling empty gel dispensers, and then obviously administrators ordering those dispensers and gels appropriately. So after specifying what needs to change, then it's important to identify the barriers and enablers to change. Why? Because then we can tailor solutions or strategies to target those things, redirect those factors. So like I mentioned earlier, there are numerous theories and theoretical frameworks that can help us with this, help us understand how individuals, teams, and organisations experience and think about behaviour change. And also they help prevent us from overlooking potentially important factors that may be operating at different levels in the health system that may influence research translation. Some of them we can have control over or modify. Some we may not be able to modify, but at least we will know and aware that they exist. The other reason that theories and theoretical frameworks are useful is that they can identify or point to strategies that are more likely to alter or redirect these processes. And many of you will be aware, but there are hundreds of theories and frameworks relevant to behaviour change and organisational change, and obviously relevant to research translation. So hence, looking at those systematic reviews or scoping reviews is a very useful first step to help to identify frameworks or theoretical approaches that may be relevant to you. But also you need to think about the goodness of fit between these particular theoretical approaches and the sort of problem that you're dealing with. You know, who are the actors that you are working with? What's the context in which they operate? Is it a complex organisational system, or is it more an individual-led behaviour change approach? So these are the sort of factors that can help inform your selection of the appropriate approach. So one example or one theoretical approach that I've used a lot in my work and have been involved in validating and refining is the theoretical domains framework. This was developed by a team of psychologists and health services researchers led by Susan Mickey. And again, the aim here is to make theory use more accessible to all of us, basically. And so to develop this framework, 33 theories of behaviour change were identified and really drilled down into key sort of theoretical domains that are presumed to account for behaviour change. You can see those in the bubbles shown on the figure. So things like our knowledge is likely to influence whether or not we enact a particular behaviour in clinical practice. What we think about the consequences of doing that are going to influence our behaviour. Our skills and our beliefs about our capability to do that, whether we remember to do it, whether we think positively about it or find it challenging to do, what our peers, our social influences are doing, and supports within our environmental context or lack of supports will also influence whether or not we perform those behaviours. So barriers and enablers to research translation, guided by frameworks like the TDF, but as I mentioned, there's lots of others, can be identified by first going to the literature, because often other researchers have already explored these phenomena and they may be relevant to your particular context. If not, then it's useful to discuss what the barriers to change are with the folk within your local organisation. You may choose to conduct some surveys or conduct some qualitative interviews or observe practice and what appears to be the barriers and enablers to change. So here's one example undertaken by one of my PhD students, where the theoretical domains framework was used to explore the barriers and enablers to uptake of evidence-based guidelines for managing mild brain injury in emergency departments. And so we conducted semi-structured interviews with doctors and nurses in relation to 4 guideline recommended practices. And one of them was about prospectively assessing post-traumatic amnesia using a validated scale. Now, this was uncommon at the time that this study was undertaken because clinicians typically were using clinical questioning to establish whether patients were oriented and if they had memory problems. And so by conducting this piece of work, we were able to identify there was sort of 6 key domains of the TDF that appeared to be influencing or were barriers influencing the translation of that evidence-based recommendation into ED practice. So that related to knowledge, that ED clinicians had limited knowledge about PTA and the validated tools that were available to assess it. Nurses spoke about their limited skills in assessing patients with neurological conditions, and they didn't have training in use of those validated tools. In terms of the environment, there wasn't a validated and mandated tool for ED settings for assessing PTA. And on a very practical level, there wasn't any space even on the ED documentation forms for including that PTA assessment information. So sometimes some very practical things can be barriers. In terms of professional role, which is a pretty important one, assessing PTA using a validated tool was seen as outside the scope of ED. It was seen more as a longer-term issue, and that it was really unclear about who should be doing it within the emergency department setting. So should it be the doctors or the nurses? And then finally, motivation and goals. The ED staff weren't convinced of the need to assess PTA with a validated tool. So that's about the sort of the beliefs about consequences. They thought it wasn't really critical for them. And so they weren't motivated to do it given all of the other priorities that they had in the ED setting. So you can see there that those, that granular understanding of the barriers to research translation is really informative then to help design the content of interventions. So in terms of then designing or tailoring interventions, the concept of tailoring makes intuitive sense. And it's also supported by a systematic review led by Richard Baker and colleagues, and that shows that strategies that are tailored to prospectively identified barriers to change increase the odds of improving care compared with non-tailored or no interventions. And we can use pragmatic approaches to tailoring like this. So we can provide education or decision aids if we identify that knowledge is a barrier, or we can draw on opinion leaders if negative attitudes need addressing or changing, persuading. We can also use theoretically informed approaches. So again, going back to the benefits of drawing on this theoretical evidence base. And how we do that is that we consider the likely mechanism of action of these types of research translation interventions. So how we think they work to enact behaviour change. And so here, again, drawing on theories from psychological and social science discipline. We have one example, the behaviour change wheel, and this links different factors influencing behaviour. So the bubbles in yellow and green that I've sort of talked about before, and some of the terms here are familiar because they relate to the theoretical domains framework. And they link those factors to interventions that are theorised to redirect or alter those things, and they're shown in red. So we're now generating a large menu of options of research translation strategies in the field of implementation science from which to draw from. And some of these strategies or interventions are shown on this slide, and they can target healthcare providers, you can see in the blue column, consumers, and then also healthcare organisations. There's also a growing body of evidence about the impact or the effects of these research translation strategies available from systematic reviews of randomised trials. And in some instances, there's loads of them. And incidentally, we've just updated that first one, that audit and feedback systematic review led by Noah Ivers and comprising lots of people, lots of authors. And we've got almost 300 randomized trials of audit and feedback now. So it's a really robust evidence base on which to actually inform selection of these types of interventions. Now, I'll mention that these different reviews of research translation interventions, they are very broad in their scope. So, for instance, the audit and feedback review looks at all types of behaviours, and it's not limited to antimicrobial prescribing. It's looking at, you know, tests and medication prescribing across the board, screening tests, so forth. So you can imagine, or you can see, that there's quite a range in the effects, a variation in the effects of those interventions across different contexts, for different behaviours, but also the way in which those different interventions have been operationalised and designed. So you can see from this table that these interventions generally lead to what some would argue is quite modest improvements in care. And you can see the effects there range from about 4% to around 11% improvement in desired practice. But as mentioned, there's quite substantial variation across those. So, you know, some of these interventions can be really quite effective in some instances and not very effective in others. And so the challenge for implementation science, and where all of our energy, or a lot of energy, is going now, is how to actually better predict when these interventions are likely to be most effective and how to optimise their effects. Despite these, what some may argue as modest effects, they can still be very important and lead to important improvements in healthcare, particularly when they're focused on high quality or high certainty evidence. That we know that if we deliver these particular interventions, or, you know, have appropriate antimicrobial prescribing, that it will deliver better outcomes for patients and reduce the risk of antimicrobial resistance, but also in areas where we've got important evidence practice gaps. So not in areas, we don't want to focus these translation efforts in areas where there's really not much need for improvement, rather direct our efforts to where we need the most change. And an average 11% improvement in desired practice in those areas is really important change. So a few examples that I have led or been a critical enabler to, using this structured approach to designing interventions. Firstly, here's one example that related to that barriers slide that I talked about just recently. And this was about improving the care of people with mild brain injury in emergency departments. And so the intervention design involved identifying those behaviours and barriers to change, informed by the theoretical domains framework and also another organisational change framework. And then we developed a multi-component research translation strategy, and you can see that comprised local stakeholder meetings, local opinion leaders, interactive workshops and resources specifically addressing those barriers that we identified. And then we evaluated this strategy in a randomised trial of 31 Australian emergency departments, and found that it led to a 14% relative improvement in appropriate post-traumatic amnesia assessment compared to control, which that was the primary outcome. Another example is the development of an intervention in collaboration with the Australian Department of Health and Aged Care, and this involved providing performance feedback to Australian general practices or practitioners who are in the top 20% of referrers for commonly overused musculoskeletal diagnostic imaging tests. So we developed that intervention, co-designed it, used theory to optimize it, and then we evaluated it again in a randomized trial, and we found that it led to an 11% reduction in imaging requests over a 6-month period nationwide, and led to about 47,000 fewer imaging tests compared to folk who didn't receive the intervention. So I've tried to give you sort of a whistle-stop tour of the main principles or processes involved in designing research translation interventions. We know that translating research is a fundamental challenge, and it is complex, and designing these types of research translation interventions firstly involves engaging with local stakeholders to identify and prioritise the most important practices to target. So that should be informed by evidence practice gaps, or perhaps audits like the NAPS audit of practice to show where you need to focus your effort, then assessing barriers to change, and then identifying intervention components that are most likely to be effective given that assessment. I hope I've convinced you that theories or theoretical frameworks can be helpful to inform this barrier assessment, and also the tailoring of interventions to redirect or alter those factors. And then there is a substantial implementation science evidence base to inform the design of these research translation efforts. And if you dip your toe in, of course, there is a huge implementation evidence base around barriers and potential interventions that can optimise research translation relevant to antimicrobial prescribing across different clinical contexts across One Health. So I would encourage you to engage with that literature when you can, and in an effort to actually drive the right care. Thanks so much for listening and taking time out, and it'd be great to hear any comments or reflections or questions from folk on the call.
Thank you so much, Denise, for a wonderful and very thought-provoking presentation. We have plenty of time for questions, so if anybody would like to ask a question, you can pop your question in the chat or in the Q&A, or just let us know and we can unmute you if that would be easier, if there are any educational interventions and things like that that you're planning that you would like to discuss. But just whilst that's happening, I have a question, Denise. So you talked a bit about theoretical frameworks and how useful they can be. And I suppose for an AMS clinician who perhaps doesn't have a lot of experience in trying to find the plethora, the relevant theoretical framework amongst the plethora of them, I'm wondering, in your experience, if you found some of them in particular to be particularly useful, that have been kind of easy to have, broadly speaking, adopted in healthcare to look at what needs to be done when designing an intervention.
Yeah, thanks for that question. Yeah, absolutely. There are, I mean, I wouldn't get too hung up on which theoretical framework. There is a lot of overlap, and particularly if you go to those reviews, they identify the sort of the usual suspects. There are those frameworks like the PDF, but there's also the CIFA, the Consolidated Framework of Implementation Research. There is the Diffusions of Innovation framework that relates more to complex organisations. So there are sort of some more frequently used and in some instances validated frameworks that I would encourage people to visit first and not get too bogged down or worried about, should I be using this one or that one or that one? I guess it's more to do with the goodness of fit of the framework to your setting. So I think I alluded to that before. If you're working, like for instance, in general practice where there might be more autonomous decision making, then you might opt more for a framework that has been developed or used in that context more frequently. Whereas if you are interested in translation in a very complex organisation, then it's clear that probably in isolation, a framework that only talks about individual behaviour change may not be sufficient, that you would need to draw on frameworks that consider factors within a complex organisation. So I think that would be my top tip, is don't get too bogged down. Refer to one, or use, draw on sort of the usual suspects, go to those reviews and look at what others are using commonly, and that will probably filter to the top, the more useful ones.
Thank you. Kaz?
Thanks, Denise. Look, I think one tip for the people online is that the one thing that AMS people do all the time is write guidelines. We jump into, let's write a guideline for this, let's write a guideline for that. My recommendation for one of the frameworks you need to carefully be very, very familiar with, and which I use all the time now, is the ACT framework.
Yeah.
Because really the ACT framework talks about who does what and when and why. We don't think about that often, and it's all very well pulling together a guideline, but you need to understand who is going to be using it, at what point is it relevant. And this is examples where it can be really very helpful areas like sepsis, where you need to know what are the nurses' role, what are the medical role, what's the role in ED, what happens in ED, what happens when you get to the board, who does what test, who reviews it. This is the one framework which I talk about all the time, because I think it actually speaks to how we work in stewardship, because we are trying to implement a system change in behaviour, but we're working within a system. So therefore, everything we do needs to reflect what part of the system we're working in. So that is one tip for me, which I use all the time now. And with regards to the others, there are other ways of doing things that actually indirectly do the same thing, right, Denise? So, that design thinking approach, when you're empathising and trying to understand what you're going to do, there are ways of getting to the same end without feeling caught up by having to have a framework, because people think, oh, I have to have a framework. You don't have to, because it depends how you're doing it. But absolutely, or as Denise said, a lot of the concepts are overlapping, and they're all trying to drive addressing how the intervention is relevant to that particular person in terms of potentially driving behaviour change, I think. So that would be my experience over the last 20 years. Many of us have actually been doing implementation sciencey things without even realising that we're doing it. It's just that you actually have a definition for it now, I think. Actually.
Exactly. So it's interesting. I mean, Kaz, what you say there about, the ACT framework, the reason we included that in our model like 10 years ago is that, reviews by others that had looked at guidelines and are reflections on guidelines that had been written, is that they were very rarely specific about who needed to do what. They just said, this has to be done. And so the first critical step we thought was about being clear about who's doing what differently. And it is often different things for different people. And you need to have clarity around whose role it is to actually, enact different behaviours. So that's why we included that in our first step. But great, if that can be included in the guidelines, then that's, it achieves that purpose. Although sometimes if you've got it in a guideline, it might need to be adapted for different settings. If you take a guideline and then want to adapt it for a particular hospital or context, it might be slightly, it might need to change a little bit. The other thing is, I guess in relation to use of theoretical approaches, the only comment I'd say there is we all have theories about how behaviour change works, about translation. We've got them all implicit. We have ideas about how this is going to work. And so drawing on these frameworks is really just making that more transparent. And we're using it in the design process, and then we can evaluate it. So I guess it's about transparency of those things, which we sort of implicitly are thinking anyway, and making sure we're all on the same page. So, yeah.
Thanks very much. We've got a few questions, so we might quickly go through those. Christina just popped a question asking for the reference to.
Caroline's just cut out for me. I'm not sure if that's the same for others, but I can provide the slides and the references, of course.
Yep, I'll jump in while Kaz is frozen.
Oh,
but there was just excellent.
Sorry about that. Yeah, there was a question just to pop in a reference for the ACT framework. So I'm not sure at what point I froze. There's so also we got a question from Ree. Hi Denise, I'm in the animal health team and we're developing a benchmarking dashboard that summarizes vet clinic level antibiotic use patterns. We want to use this to drive down the proportion of high importance antibiotics used. Do you have any hot tips on how to create the biggest impact with a benchmarking dashboard?
Well, I guess it's the same thing about being clear about who needs to do what differently. I mean, obviously your indicators are related to, you know, evidence-based guidelines. And so you want to be clear about who needs to do what differently, and make it very prominent in terms of the information that they need to absorb, because sometimes dashboards can be overwhelming with the amount of data. And I would talk to your end users with your vets about how they interpret that data, how they're going to use it, how convincing it is to them to actually motivate change. Because again, it's one thing to have the knowledge about the evidence, the knowledge about gaps, but then it's another thing, the whole, you know, thinking back to the green bubbles on that figure, people's engagement with and motivation. So providing a dashboard is basically providing feedback to practices about where change is needed. So it needs to be motivating. So there are lots of theories about how to do that, and that's a particular area of interest of mine. So I'd be happy to talk to you more about that offline. And you know, certainly we've done lots of trials in that area.
Thank you, Denise. We also have a question from Katina, so we'll just unmute you, Katina, so you can ask your question to Denise. Yep.
Hello, thank you very much, Denise. My name is Katina, and I work in a small organization a health organization, where the medical teams are predominantly GPs. And I did a implementation science subject from my Masters of Infectious Diseases with Natalie Taylor at UNSW. And yes, I can confirm I was really confused about all of the different theories. So I guess part of my question is, I did a practice project proposal on driving down urinary tract infection antibiotic use and improving management. And my key question is there a particular framework? I know you just said don't worry too much about frameworks. Is there a particular framework for which you think suits better for this type of project? And my second question is there any particular literature directly and specifically about this you could direct me to? I did use a lot of Michie's literature in my preparation.
Yeah. I mean, I'm a little bit biased in that I use the TDF all the time, and it's been used a lot in primary care, so it's really relevant. It's been validated. It's been used, you know, in hundreds and hundreds of studies relevant to primary care. So that is a really simple one. But there, as I say, I don't want people to get caught up you know, there's so many theoretical frameworks. I wouldn't get too worried about it, because the usual suspects, when we map across them, they have similar domains. They're drawing on similar concepts. The only thing I would say is, if you're working in hospitals or nursing homes where there are other complex organisational structures, you might want to supplement or draw on some of those other organisational frameworks. But I think for you, Katina, probably, you know, the TDF or the CIFA, you know, a consolidated framework for implementation research, some of these commonly used ones will be absolutely appropriate. And then what was your second part of the question? Sorry, I lost it.
The second part was any particular literature that you can direct me to. And also just thanks, that's confidence building. I did use the TDF and the CIFA, the MOA, the ISPBA, IPSQ, the patient survey, Excel spreadsheet one.
Yeah. So, I mean, you know, and that's my top tip is, you know, getting your head around this when you're working in a specific clinical field. It can be a bit daunting because there's different terms, there's all these frameworks, but I guess I'm trying to convey the general principles and to not get hung up on that. Now, in terms of antimicrobial prescribing for UTI, there is, I would say, a defined literature base and probably some reviews that I would point you to. Don't have those references on me right now, but definitely I could flick those to Caroline to pass on to you, or you feel free to reach out to my email and I'll flick those through to you. But yes, there would be relevant implementation research that would help inform what you're doing, and also you might supplement it. So you might look at what barriers have been identified in primary care that may have been studied in other, you know, jurisdictions, and then you could say, okay, do these things resonate with what I'm experiencing or observing here? So it's always useful. We are very rarely unique in what we're asking. There are other people in the world asking the same questions. And so the first step should not be us going and doing primary research. The first step should always be looking at related literature. And so yeah,
great, that'd be excellent.
And I'll send you a few, because I remember doing when I presented last November, when Caro mentioned, or last year when I presented another workshop, you know, I had a look at the systematic reviews related to AMS, and I think I found hundreds of systematic reviews, in lots of different contexts. And so there's a lot of literature that's highly relevant that people, you know, should look at before going and doing their own stuff.
Great, thank you so much. Ta.
Okay.
Kaz?
Yes, I absolutely agree. The other thing to discuss, Denise, is, you know, we've done all this work. We've understood what we need to do. We understand the knowledge gap. We need to know. We understand the barriers and facilitators and what we're going to design. And you go ahead and design this intervention, and then they don't use it.
Yeah.
So the next phase is considering what we call the human factors elements as to why people won't do something the way that you think they do.
Yeah.
This is a very important overlap, drawing on some elements of implementation science, but also drawing on what we call human factors and ergonomics. And obviously Denise and I are very interested in this because there's an overlap and it's a continuum of your implementation project.
Yeah.
Now, to make sure that your intervention is fit for purpose, you need to continue that work with engaging your stakeholders and building them into that, understanding exactly what they're going to use, how they're going to use it when you're doing the co-design and piloting and evaluation. And then evaluation has its own frameworks, which we won't go overboard with here, but we might have another session on that. But did you want to comment on that, Denise?
Yeah, I mean, again, building evidence base about human factors and co-design. So in all the work that I do now, and I guess I didn't really specifically highlight it there, but the work that I do now and the design of interventions is always involving stakeholders, the target end users, because if we're not involving them in the design process and then it doesn't work or it's not used, not surprising really that those who we are wanting to translate the evidence into practice don't feel that it's fit for their ways of working or fit for purpose. So absolutely agree. And yes, we routinely involve co-design end users working with us. We can bring our knowledge, they bring their experiences of their ways of working and how the strategies that we think might work can fit in with their normal ways of working to actually influence change. And so you can have the Rolls Royce of what you think based on theory and evidence, but if it doesn't fit with folks' ways of working, then it isn't going to be effective. So we need to bring that in as well.
Thank you. We only have a couple of minutes left this morning, but I do have one question. You touched on a bit about de-implementing and scaling back interventions. And I think of in AMS, it's often obviously easy to keep piling on new interventions. And so I wondered if, you have any tips on identifying things that are not working that need to be de-implemented? Is it really just about regular monitoring and audit and feedback? And also if you have any specific tips on the key things when you're trying to remove or de-implement something.
Yeah, so in terms of de-implementing, we think about practices that need to be de-implemented, removed or reduced when we have high certainty evidence that they lead to little or no benefit to patients or can cause harm. And I'm sure there are some in, obviously in antimicrobial prescribing that's of relevance. So we're talking about the clinical practices where we have evidence that either a particular test or treatment works and we want to get that into practice, or something that we know is potentially harmful or ineffective and we want to reduce or remove that from practice. So I think one of the points that I made is getting people engaged and agreeing on and primed and familiar with this at the outset is really important, because we think it's probably harder to reduce or remove ineffective practices that have been happening in clinical practice than to translate effective care, because clinicians are more likely to adopt new things that they think work. In terms of some of the top tips, so probably it's easier to do when we can substitute another practice, clinical practice. So, stop doing this, but you can instead do that. Where we don't have a substitute, it's a lot harder. And if a particular discipline, if it's very wedded to their identity, or, obviously if it's an income earner, if there are sort of the drivers are reinforcing delivering that low value care, both individually, but also within the system, if there's remuneration for low value care, then it's much harder to remove. So we have levers at different points in the health system, things at a local level, but then there is also levers, regulation, financial incentives, all of those sorts of things. And some of those levers need to be used when low value care is present.
Thank you. Thanks so much, Denise, and thank you to everyone for attending online. It was a really, really fantastic session and lots of robust discussion afterwards. So thank you, Denise, and I might just hand over to Josephine just to talk about our next webinar for next month.
Thanks, Caroline, and thank you, Denise, for the excellent talk. This session this morning was recorded, and we'll be making a recording of this available on our YouTube channel. The next session we'll have an animal health focus, and that is scheduled for August 21st. So we hope to see you all online again. Thank you.
Thank you so much, everyone.
Thanks, Denise. Thanks, Kaz. Thanks,
Thanks, everyone.
Thanks, Denise. Thanks.